All right, I'll try to keep this fairly short. I'll try to do the 5-minute version of covering all kidney stones that I was supposed to do in 10 minutes, but I wanted to leave a little bit of time for discussion and questions. And I've given this talk before in the same venue, and as I think if you've been here for this, I am happy to stick around or stay around afterwards and answer any questions. This is a large kidney stone called a staghorn, which is very popular in this part of the country. As you can see, it is a favorite of deer hunters. This basically forms a cast of the kidney, and it occurs in a small segment of patients, but we see it actually fairly common here. This is also just gives you a size. These are centimeters, not inches. So this is about 2.2 centimeters in an inch, 2.54 centimeters in an inch. So that's a roughly 2 centimeter ovoid stone that we take out of the urinary tract. Greater than 1 million patients a year will develop stones in this country. That's about 3 to 5% of the American population. Men are much more common, but that gap is narrowing significantly. About 1 in 7 men in this country will develop a kidney stone. And it used to be, when I first started giving this talk in the 90s, early 90s, it was about 3.5 to 1. That gap is narrowing, probably because of the diet, obesity, and just the patient's mobility. Our population has become a much more mobile group, and we are starting to do all of the same types of things, same types of habits, same types of diets. Children, I rarely talk about children's stone disease, but we certainly can. They're much less common. They have a very atypical presentation. I think if you remember nothing from this entire day, remember this. Recurrence rates of stone disease is extremely high. And in our clinic at SIU, we try to make a very concerted effort to try to prevent stones from recurring. And it's because of this. After a year, if you do nothing, 1/3 of you will develop another stone. After 5 years, at least half, if not more, will develop a stone. And at 10 years, the vast majority will have another stone recurrence. So we do emphasize stone prevention. It's difficult, but possible. How do these stones present? Well, the vast majority, as most people will kind of associate with, they have pain. That pain is typically in the flank, in one of the sides. It can radiate around to the front, go down to the testicle or vaginal area. Abdominal pain, nausea, vomiting, urinary symptoms such as urinary urgency, frequency. They can present with fever, which is a urologic emergency if they are infected, and that could be a situation where we have to intervene urgently. And they can be asymptomatic. And typically, the bigger they are, the more asymptomatic they are. So it's the small 2, 3, 4, 5 millimeter stones that are obstructed in the ureter that tend to be the more symptomatic stones. And if you take one of these out, it kind of looks something like that. And again, you're looking at about a 3 to 4 inch stone that came out of that person. How do we diagnose them? Just like we diagnose virtually any disease in medicine, there's a history, a physical exam, some labs that we might have. 90% of stone patients will have blood in their urine, whether it is microscopic or blood that you can see. And then we have a series of x-rays that we might employ. In the year 2014, the vast majority of these stones are diagnosed by CAT scan. Tremendous amount of research that we're also doing here is centered around decreasing radiation exposure to these patients, using larger slices, lower doses of radiation, faster scanners, etc. We're trying to minimize the radiation dose, but CAT scan is clearly the way that we do most of them now. Ultrasound, we follow a lot of stones, and the plain abdominal x-ray, the KUB, is something we can follow stones or confirm treatment results. About 80 to 85% of all stones in this country are calcium-based. I will talk about that in a second. The next highest number are infection stones or struvite stones. These mainly occur in women, but not always. We also have a very significant population of spinal cord injured patients with bladder dysfunction. We have a large struvite population in them as well. About 5 to 10% uric acid stones, and then there's several rare stones that we occasionally see. What are the treatment modalities? A lot of stones, in my practice, if they're in the kidney, we can actually observe them. We don't have to treat every single stone. If the stone is in the ureter, I would argue that we should do something at some point. If you're in pain, you can't function, your lifestyle is inhibited, you can't work, etc., we should probably do something. If the stone is in your kidney, it's not growing, we're following it, you're asymptomatic, we can watch it, we don't necessarily have to intervene. Dissolution in 2014 is basically boiled down to uric acid stones. We can actually dissolve about 1 centimeter a month by taking 2 different pills a day. Then the 4 different types of intervention surgically that we have, there's lithotripsy, which is ESWL, that's what the water bath that some people are familiar with. Ureteroscopy, percutaneous surgery where we go in through a very small hole in the back. And then there's open laparoscopic robotic surgery. I'm not going to really go through these because this in and of itself is a textbook with 2 or 3 volumes discussing a lot of the ins and outs. But every single stone is different, every surgeon is different, and it requires a very thorough interaction and discussion with the surgeon to figure out what treatment is best for you and the stone. Not one size fits all. And then lastly, how do we prevent them? If you can tell me how stones occur, why they form, and how we can prevent them, you should get the Nobel Prize. It's that complex, and I really believe that the people who are working on this in the laboratory will be recognized somehow internationally for their work because it's very evasive. We get some blood tests, we get some urine work. The urine laboratory is basically taking a kit home, collecting your urine for 24 hours, looking at some laboratory work, and then trying to determine what dietary or medical modifications we can employ to help you prevent these stones. What are some of the possibilities? We have certain medications that we can use. There aren't as many as you'd think. There are probably realistically about 3 or 4 different medications that we can use depending upon what your findings are. Dietary changes are huge. Unfortunately, we can't change genetics, and we do think that stones are probably chromosomally passed on. Almost all diseases have some genetic or chromosomal aspect to them. Fluid modifications. I just saw a woman literally an hour ago whose 24-hour urine production was 600 cc's. For those of you who can't get a grip on that, most adults void, on average, roughly 300 to 400 cc's per visit to the restroom. So that means she peed twice in one day. So that's a risk factor. That's bad. And then surgery could be a preventative treatment in some cases, but it's fairly unusual. If I have to leave you with a tidbit, the 3 general recommendations that we make for you to help prevent stones from coming back are increasing your fluids. You need to void greater than 2 liters a day, which amounts to drinking roughly a gallon of fluids a day, 4 liters per day. Lemonade, water are the best, but right now there's actually a lot of research to indicate that the type of fluid you drink is probably not that important. It's the quantity. Decreased protein, mainly in animal meats, specifically red meats. That may be changing a little bit, but as of right now, high intake of red meats is probably not good. And the last thing is salt. You need to decrease your sodium intake. It has a profound effect on a number of different physiologic functions. Stone disease is one of them. And then I leave you with a myth. If you have a calcium stone, you need to avoid all calcium in your diet. We hear all the time that I have a calcium stone, avoid your calcium, throw everything away. Actually, the latest research over the last 5 years would indicate the absolute contrary, and that a lot of oral calcium appears to be preventative for stone disease. So not only do you need to take calcium, but 30% of my stone patients will have hyperoxaluria, which is a condition where the gut produces too much oxalate. The treatment for that is eating or drinking calcium with each meal. Furthermore, the older the patient, the more risk they are for osteoporosis. Calcium is a very, very significant benefit in that disease. And so oral calcium is extremely important. I tell my patients I'd rather have them have a stone than a fractured hip. Lastly, I've had 3 stones, and I've had surgery for 2 of them, and I've had stents, and I've gone through a lot of that, so I feel a little bit of sympathy for my patients. But I'll wrap it up there.